Thank you. Good morning. My name is Kris Ehresmann, and I am the Director of the Infectious Disease Epidemiology Prevention and Control Division at the Minnesota Department of Health. I'm also the parent of 2 fully vaccinated young adults. Today, the Minnesota Department of Health is proposing rules that would update the current child care and school immunization requirement to reflect evidence-based national immunization recommendations. The proposal does not add any new vaccines to the schedule. The proposed additions to the law are vaccines that are currently recommended for children and adolescents and have been for years. These changes will align Minnesota's immunization law with the national standards. It is important to note that the proposed changes do not alter Minnesota's philosophical exemption. Parents will continue to have the option to exempt their children from the requirements of the law based on a philosophical belief, that is, objecting to vaccination on the basis of personal, moral, or other beliefs. Only 19 other states allow for a philosophical exemption. The Statement of Need and Reasonableness, or SONAR, lays out in detail the Department's rationale on why we believe these changes to the immunization rules are reasonable and necessary. I'll highlight just a few points for you this morning. Although the school immunization law was first introduced in 1967, when kids had metal lunch boxes, gas was 33 cents a gallon, and I was in kindergarten, it remains an important public health tool. Despite the widespread success of the vaccination program, vaccine-preventable diseases remain a threat. Minnesota recorded 4,485 cases of reported pertussis in 2012. That is the highest number of cases since 1938. Just 3 weeks ago, we received word of a polio outbreak in a refugee camp in Kenya. 31 newly arrived refugees to the state had been exposed at this camp. Fortunately, none of these persons developed polio disease, but the situation was a reminder that vaccine-preventable disease is just a plane ride away. Additionally, child care and school-based immunization laws help to assure that we have adequate herd immunity in the community to help reduce the likelihood of disease spreading and to protect individuals who cannot be vaccinated or whose immune system cannot generate a response to the vaccine. Studies have shown that school and child care immunization laws result in higher overall immunization rates and thus greater protection for the children and the community. Currently, in Minnesota, 98% of kids have received the required vaccines by the time they enter school. One issue that often accompanies discussion about vaccination laws is the question of vaccine safety. And while it's discussed in our SONAR, I will provide a brief overview of our vaccine safety system this morning. Vaccine licensure is the final step in a 3-phase process that can take a decade or longer. Monitoring for adverse events following vaccination occurs in all 3 phases of vaccine clinical trials. In order to obtain an FDA license, a vaccine must be shown to be both safe and effective and to work in the people who will be vaccinated at the ages it's recommended to work. The vaccine cannot interfere with the safety or effectiveness of existing vaccines. FDA licensure by the Food and Drug Administration, does not constitute a recommendation for vaccine. It just means that it is legal to use in the United States. The Advisory Committee on Immunization Practices, or ACIP, is a group of medical and public health experts that develops recommendations on how to use vaccines to control disease in the United States. I have been a voting member of the ACIP and can tell you members take their job very seriously and thoroughly review the studies and evidence before voting to recommend the addition of any new vaccine to the schedule. Even after licensure, safety and effectiveness of vaccines is tracked. Because all potential adverse events cannot be anticipated prior to licensure, vaccines undergo phase 4 studies, formal studies on a vaccine once it is licensed. There are 2 major systems that are used in this process. The first is VAERS, or the Vaccine Adverse Event Reporting System. It is important to point out that anyone can report an adverse event that they think is related to vaccination to VAERS. Staff at the Centers for Disease Control and Prevention, or CDC, are continuously reviewing VAERS reports and watching for patterns of adverse events. Serious reports are closely evaluated. This system is used to generate hypotheses and detect signals that will then be evaluated under stringent scientific methodology. VAERS does not determine that the vaccine caused an event, which is why it is important that no conclusions are drawn from the number of reports to VAERS on a given vaccine. The Vaccine Safety Data Link, or VSD, was formed in 1994 as a collaborative effort between CDC and a group of managed care organizations to maintain a large linked database for monitoring immunization safety and potential rare and serious events. The database contains information on over 9.5 million children and adults. Whereas VAERS can raise a question about whether a vaccine caused a particular problem, the Vaccine Safety Data Link can answer it, because the Vaccine Safety Data Link offers something VAERS does not, which is a control group. Finally, there is the Clinical Immunization Safety Assessment Network, or CISA. This is a national network of 6 medical research centers with expertise in immunization safety, conducting clinical research on immunization-associated health risks. CISA studies possible ways that certain vaccines might cause adverse events, and they also serve as a regional referral center to address complex vaccine safety inquiries. Let me give you an example from my personal experience. In 1999, VAERS identified a signal linking intussusception, a rare form of intestinal blockage, to the rotavirus vaccine that was used at that time. CDC instituted a number of studies, including a case control study in Minnesota that I helped conduct. These studies were done within the span of a month. The initial data showed that there did appear to be a link between the vaccine and intussusception. It was recommended that vaccination be postponed until more data were available, which was coming, and the vaccine was formally withdrawn from the market in November of 1999. So the system works. In addition to this safety tracking system, the Institute of Medicine, or IOM, has reviewed a number of immunization-related issues, and we do have a listing of this in the back of the room. University researchers also continue to conduct vaccine-related studies. Groups who have concerns about the safety of vaccines have called for studies looking at vaccinated and unvaccinated children. However, the most recent Institute of Medicine report has advised the Department of Health and Human Services and the CDC against doing this type of study because it requires a random sample of children from whom to withhold vaccination, and it is unethical to withhold a medical product that is known to have a significant benefit to children and adults. Other specific vaccine concerns that are frequently raised have to do with the growing number of vaccines that children are recommended to receive. It's easy to see why a parent might have questions. In reality, although the number of vaccines has increased, providing children with protection against more diseases, the number of antigens or immunologic components that the child's immune system must respond to has decreased. Vaccines have been improved. In 1960, children received 10 vaccines by 2 years of age, but they represented 12,053 immunologic components. In 2013, they received 30 vaccines, but need to respond to only 314 immunologic components. Every day, a baby's immune system faces more immunologic challenges in the environment than from vaccines. In fact, the ACIP, or Advisory Committee on Immunization Practices, would not recommend the simultaneous administration of vaccines unless studies showed it to be both safe and effective. I am now just going to discuss the notable of the proposed changes. The department is recommending that hepatitis B vaccine be required for child care and early childhood programs. The vaccine has been recommended for all infants since 1991 and for all children since 1999. 41 other states, or 82% of states, include it in their child care laws right now. Infant hepatitis B vaccination was recommended because although the majority of symptomatic cases occur in adults, the burden of chronic hepatitis disease occurs in childhood. Unfortunately, infection acquired in childhood, particularly in infancy, is more likely to result in chronic diseases and can result in liver cancer and liver failure of young to middle-aged adults. Recommended perinatal screening for hepatitis B can catch many infants when they're born if they receive prenatal care. But infants can acquire their infection from other close family members or household contacts who have not been identified. The hepatitis B vaccine has been given routinely to infants for over 20 years and has a proven record of safety. The SONAR does include a bibliography of studies that have looked at the safety of the hepatitis B vaccine. The department is recommending that hepatitis A vaccine be required for child care and early childhood programs. Young children disproportionately contribute to the spread of hepatitis A, which can have severe consequences in adults who may have been infected by a child. This vaccine has been part of the routine childhood schedule since 2005. It was first introduced in states with very high incidence of hepatitis A, for example, the West Coast, and the vaccination program resulted in a dramatic drop in hepatitis A disease in all age groups. The current hepatitis A disease outbreak linked to organic frozen berry mix from Costco is a tale of the success of vaccination. It was expected that many children might get the disease, but to date only one child has developed illness, and that child was unvaccinated. The widespread use of the vaccine on the West Coast has ensured that children are protected and not developing disease. In Minnesota, we had an outbreak of hepatitis A that resulted in 16 cases of disease, including severe hepatitis A necessitating a liver transplant and ultimately resulting in death. The vaccine has been in use since 1995 and given to both children and adults. No safety concerns have been identified. The Tdap booster is being added for students in the 7th through 12th grades. As I mentioned earlier, Minnesota had 4,485 cases of pertussis in 2012. Pertussis is a real problem in Minnesota and nationally, and the vaccine is safe and effective. Meningococcal vaccine is being added to the 7th through 12th grade requirements as well. This disease is rarer than the other diseases that we have discussed, but if a person gets the disease, it is very serious. 9 to 12% of individuals will die, and of those who survive, 1 in 5 will have permanent disabilities. Meningococcal disease incidence begins to increase in early adolescence, peaking around age 19. The vaccine effectively protects teens against this rare but serious disease. There has been close scrutiny of the vaccine's safety since it was recommended in 2005, and it has been determined to be safe. My 2 children have received all of these vaccines. In conclusion, MDH feels the proposed changes to the school and child care rule are reasonable and necessary. They represent evidence-based recommendations that have been in existence for a number of years. The proposed vaccines are safe. They have been used by millions of children and are monitored via an extensive vaccine safety system. The rule benefits the children who are vaccinated, those who cannot be vaccinated, and the community. Thank you.